Well, good afternoon. It's great to be back here. I've spoken at a few of these over the years now, and it's it's a tremendous group of folks that are brought together from lots of different places and representing lots of different points of view. And I appreciate the fact that imaging is involved. Amy's talk I want to mention. So we've been using shim for collagen in the bowel now for our last two big projects, going back 3 or 4 years, and it does seem to be performing really, really well, particularly when compared to human pathologists, because they, this just very hard for them to exactly agree with one another, whereas the computer sort of is much more objective. So I'm excited to see that the liver is sort of following the bowel and what Ted and I have been doing over the last few years. So now let's talk about imaging of the liver, some disclosures. So in the next 20, 25 minutes here, say I have a clock, that's good. We're gonna give a called imaging update, just a few slides, talk about 2 recent projects, one that's been completed and just published over the summer, and one that hopefully will be accepted for review actually in the next couple of weeks. And then we'll wrap up by talking next steps. So a CCHMC called registry update. To date, 198, almost 200 dedicated research, not clinical. These are research MRI examinations performed literally about 100 yards from here, that way, dedicated to the liver and the biliary tract. 86 of our patients have baseline imaging, waiting on follow-up. 66 now have baseline and then a full year of follow-up. And then 46 of our patients now have had at least 3 longitudinal or serial MRI examinations. So this is incredible. And I want to point out, this is an incredibly unique, sort of one-of-a-kind database here, that when you put it up against the rest of the called database and understanding our patients' histories and our laboratory values and how these things change over time, this is an incredible resource. And I want to thank everyone who's been able to make this possible, whether it's folks providing money, whether it's parents and patients. This is tremendous. To date, from an MRI aspect of called, we're at 10 publications and counting. There are several actually out for review right now. And if you look, there's lots of different names, lots of people in this room. You'll see there's lots of different topics, from using MRI biomarkers to predict who's going to go on to portal hypertension, to using MRI and specifically quantitative MRCP and AI to predict who's got AIH versus PSC, ASC, which actually works incredibly well. That had some area under the curves of between 0.9 and 1. So there's a range of projects here, and here's even more projects. So again, a big thank you. These I think are going to lead into the next projects we're going to do as bigger groups, whether it's through the children's group, whether it's through A-Link. There is lots of validation to be done. So that's sort of the update overall called MRI. Let's talk about now MRI and some of our biomarkers, some of our sort of what we think are most likely to be successful biomarkers and how they correlate with pathology. Going a little bit back to Amy's talk. So how have we normally looked at liver fibrosis by MRI? One, we've looked at just what's the shape of the liver, what's the morphology of the liver. Is the surface of the liver nodular, like you can see here? It's very lumpy, bumpy. And that's because there's underlying scarring and capsular retraction. Are portions of the liver getting abnormally big, typically the caudate lobe, and then our other portions getting atrophic. You can see here along the surface of the liver, there are all these areas where the liver has basically kind of disappeared and undergone atrophy. The problem here, looking for these morphologic changes, they're basically impossible to quantify. I can say, yeah, there's moderate or severe fibrosis. By the time I see this sort of late in the game, we need something that can detect it earlier and more quantitative. At MRI, we can look for signal changes. Typically, we look for sort of patchy reticular areas of increased T2 weighted signal in the liver, or areas of altered post-contrast imaging. But again, same issues as before. By the time we see them, we're moderate to late in the disease, and they're difficult to quantify. And these are all patients. These are 4 different patients, T2 weighted images from our called cohort. And you can see every one of these livers. Now there's a combination of PSC and autoimmune hepatitis and ASC in here. They all look entirely different. So just looking at them morphologically or by the eyeball, it's really, really hard to say, the amount of inflammation, the amount of fibrosis, and or predict future sort of impending outcomes. So ultimately, we have this unmet need. We need non-invasive, well-tolerated methods for accurately and most importantly, objectively or quantitatively detecting fibrosis and or inflammation, measuring it, coming up with an exact number, and then following it over time. So briefly on quantitative MRI. So just remember the MRI scanner. If anybody, maybe you took a chemistry class in college or something along those lines is a spectrometer. Specifically, there was one type of spectrometer where we may have used like an organic chemistry called an NMR, nuclear magnetic resonance spectroscopy. Gave you signals, and you got a bunch of kind of squiggly lines on a piece of paper, and then from that you could tell what the structure of something was. Turns out you can use those signals and basically create our MRI images. That's exactly what an MRI scanner is. It's just a fancy NMR scanner. And now with this MRI scanner in the body, non-invasively, we can get at stiffness, liver fat, liver iron concentration. And then these unique characteristics, one of which we're going to focus on, that are called T1 and T2 relaxation. And it turns out every tissue in the body has its sort of normal range of T1 and T2 relaxation, and they differ between all the different tissues, and they change over time with disease. As disease progression, T1 may go up or go down depending on what the disease is. Stiffening, so we can measure that with MRI. These are 3 different maps. They're called elastograms. You want your liver to be kind of blue and homogeneous. You can see on the top, that's pretty much what we have here. And then as we go down, you can see it becomes more yellow and green and heterogeneous. And by the time we get to the bottom, it's a very red, incredibly stiff liver. And we use stiffness as a surrogate for fibrosis, keeping in mind that there are other things. It's just stiffness we're measuring. So severe inflammation, perhaps severe cholestasis, can also impact stiffening. How do we measure stiffness? We actually put a paddle over the right upper quadrant of the abdomen, and it vibrates, causes the liver to do these little microscopic kind of micron level jiggles. These jiggles are waves going through the liver, and we can actually image them. And then those wave images get converted into the elastogram that you can see on the bottom. And then we can take measurements on the map on the bottom and get what's called the shear stiffness. It's in a unit called kilopascals. And if you were an engineer and somebody said, you know, how hard is this block of rubber or metal or whatever, you would actually use the shear stiffness in kilopascals to get at that. So that's what we're doing. It's pretty cool. And we can do this now on any major modern scanner, Siemens, GE, Philips. So those waves you saw, a normal liver will have very thin waves. An abnormal liver, a fibrotic liver, will have thick waves. And then when they're really, really fibrotic, you can see this is probably the thickest waves I've ever seen here. So that's elastography. The other technique I really want to focus on here is the T1 mapping. And I mentioned all tissues in the body have unique T1 and T2 relaxation times, and that they vary by tissue and that they change with disease. T1 mapping in the liver, this T1 relaxation, as best we understand it, relates to the amount of extracellular water within the liver. Extracellular water in the liver goes up with both inflammation and with fibrosis. So it's sort of a fibroinflammatory marker. As T1 values go up when we measure them in the liver, there's more sort of, we'll call it injury. And that injury may be inflammation and or fibrosis. So how do we do it? One breath hold. We actually get the 8 images you can see on the top left. Those 8 images undergo processing to give us a map like you can see on the bottom left. And that map of the liver, now if I draw circles on there, it actually gives me in milliseconds what the T1 relaxation is. And normally for liver, 500 to 800 in that range. This is one breath hold per slice. We can then, and what we do these days is send these images off to the United Kingdom. They get uploaded to a HIPAA compliant cloud. The folks at Perspective download them and then do what's called T2 star correction. They correct for the strength of the magnet we're using, typically 1.5 or 3 Tesla. They look at the scanner manufacturer and they adjust for all this. And then you get this lovely color map of T1 that's adjusted for all those parameters. And in theory, if we're doing a clinical trial, for example, or doing something in the future through A-Link or through the Children's Network, whether we have Siemens, GE, Philips, 1.5 or 3T scanners, et cetera, we can go through this process and basically normalize our data. And you can see that this patient, a normal liver is going to be homogeneously green. And you can see all of this peripheral patchy increased red and purple signal, which is either going to be inflammation or fibrosis. And this also gets at the biopsy. What if I biopsy and stick a needle right here? You know, I'm going to get a pretty normal liver. If I stick a needle right here, I'm going to get a completely different liver, either, you know, extensively more fibrosis and or inflammation. So, you know, I think, you know, at some point, this sort of imaging may be used to actually guide where we do our biopsies. And I don't think, you know, with MR and the OR, we actually have the ability, we do some masses, for example, doing an, you know, image guided biopsy using MR. That's just something to think about in the future. So here's 2 different patients with T1 maps. On the left is a patient that's got a mildly elevated T1, normals less than 800 or so. You can see it's 879 there, but it's a very homogeneous liver. Wherever I biopsy there, I probably get the same, you know, pretty similar result, Medivir and whatever inflammatory index I use. The liver on the right, much higher T1 values, but equally important. Look how heterogeneous this liver again is. Depending if I biopsied here versus back here, may get entirely different results. And we think, as an aside, this heterogeneity of the T1 map here It's something that we're looking at called the IQR, or interquartile range, basically kind of is all the data, one measurement, or is there a range or spread of data? We think that spread of data, the more heterogeneous the liver is sort of based on T1, may actually be an important biomarker. And I've got some results on that in a couple of slides. So does liver stiffness and/or these T1 values correlate with histology in autoimmune liver disease? So with the help of Amy and Alex, we identified our called registry patients that had a liver biopsy and a research MRI within 6 months of one another. The biopsy tissue was actually taken from pathology. This was clinical tissue and was, after the fact, now rescored by an expert liver pathologist. And we used the Medivir system, F0 to F4, F0 no fibrosis, F4 cirrhosis. So that was used to score fibrosis. And then we scored for inflammation using the modified hepatitis activity index, which goes from 0 to 18. We then went back to the research MRIs, documented the stiffness, the CT1, and that CT1 IQR I mentioned. And all of these liver measurements in the MRI we do 4 levels, 4 slices through the liver, and then take an average result from those 4 slices. We then simply correlated our biopsy results with our MRI results. This gets back at that CT1 IQR. I just wanted to bring it up one more time. You can see how heterogeneous the liver can be, which shows you what we talked about by biopsy, but also this heterogeneity we think may be a biomarker. And the more heterogeneity, kind of the wider this sort of curve is going to be, and the spread is going to be a little bit different, and your IQR is going to go up. So correlating with pathology, our median age technically was actually 16 years. The median stiffness is 3.1. So a normal stiffness is less than 2.5 to 2.7. So on average, our livers are going to be stiffer, not necessarily surprising. The median CT1 values were just a little higher than normal, but there was a pretty good range. And you can see on the histograms, here are the range of stiffness. The normal stiffness should be below 3 here, 2.5 to 2.7. We have a lot of patients with stiff livers. And then same thing for CT1, I mentioned less than 800, and there's a fair number of our kiddos that are above 800. If we look at the liver fibrosis, the median score was 1.5 with an IQR of 1 to 3. So there's a range of fibrosis there. And the median hepatitis activity inflammations or hepatitis activity index score was 3 with an IQR of 2 to 4.8. So some inflammation. Doesn't go all the way up to 18 on average. I think our highest patient had a score of around 13. Now, here's where things get interesting. Stiffness versus Medivir fibrosis. Correlation coefficient of 0.69, 0.7. You can see the Tukey box plot here on the right. As fibrosis goes up along the bottom, liver stiffness goes up. And you don't see much of a change when you have minimal fibrosis, but once you get to 2, 3, 4, we can see it stepwise goes up. Also keep in mind, as we talked about, pathology is sort of a silver gold standard, if that makes sense to anybody. If we have 3 pathologists review the same results, 2 will say F2, 1 will say F3, 2 will say F3, 1 will say F2. So it's very hard to get perfect results for imaging studies when they're going up against pathology, when the pathology itself has issues with sort of imperfection and inter-reader sort of disagreement. When we look at stiffness versus inflammation, you can see that they're also positively correlated, correlation coefficient of about 0.6. CT1 is interesting, less correlation with fibrosis and more correlation with inflammation, which you can see here. This is a scatter plot now, inflammation score along the bottom, CT1 going up. A couple of outliers down here towards the bottom, but in general, as your activity index goes up, your inflammation goes up, your CT1 values go up. And then CT1 IQR looks very much like the fibrosis plot I showed you on the prior slide for stiffness. You can see as our fibrosis score goes up here along the bottom, the CT1 IQR pretty narrow, not a lot of spread in our data, and all of a sudden the liver becomes quite heterogeneous as our fibrosis scores get high. There's one statistical outlier right here that, yep.
I think, but don't you think that it actually looks better than the liver stiffness, because you can see the true Medivir already goes up. So that's where a lot of problems exist nowadays. Detecting early fibrosis by imaging. Late fibrosis, what do we need an MRI for? But early, so that you can actually see whether a clinical trial helps to reduce from an early to low fibrosis.
I don't disagree, and this is where your interpretation. I think these plots look pretty similar, but you're right. Here's the other interesting thing. if we had another pathologist look at this, what if this patient here that's an F1 is actually probably an F2, and all of a sudden, even we get even a little better separation. So, it's interesting.
One accuracy compared to MRE.
Accuracy meaning, sorry.
Well, if a patient has a normal MRE,
Yeah.
but has a.
Yes. So that's a great question. We have not looked at that. That's on the to-do list, is the discordance. So the patients with a normal stiffness but an abnormal CT1, what does that mean under the microscope? So that is on the short-term to-do list, is to look at those discordant cases, because that maybe where the money is, so to speak. Great question. The other thing we can do is these multivariable analyses where we can look at, okay, we've got age, we've got sex, we've got the histology for inflammation and the histology of fibrosis, put them into a multivariable model and figure out what independently of these factors, inflammation, fibrosis, age, sex, what is driving stiffness. And it turns out the only driver of stiffness in this case was the Medivir fibrosis score. And it was, very high association. And what this gets at is for every 1.5 unit increase in your Medivir scores, your fibrosis score goes up by the pathologist every 1.5 units, or goes up every unit from 1 to 2 or 2 to 3 or 3 to 4. Your liver stiffness goes up 1.49 kilopascals. So that's kind of the interpretation there. But inflammation was not independently associated with stiffness, which is good. This means stiffness and fibrosis are very much, intertwined together. CT1 is different now. One, there was actually a sex difference. Girls were a little higher on average than boys, which we can adjust for that and count. Not sure why, but it's probably a real thing. But here, the independent driver of CT1 was inflammation, and you can see that Medivir fibrosis didn't come in. So CT1 seems to be driven by inflammation. Liver stiffness seems to be driven by fibrosis. So that's very, very interesting. And now we go to Alex's favorite biomarker, which is the CT1 heterogeneity. And also that is independently driven by Medivir fibrosis score, not inflammation. And there was an age effect too. For every 1 year increase in age, there was a 5.5 increase in the CT1 IQR, which is pretty small, but it is what it is. So this is very, very interesting data. This data does not exist in peds out there. It does not exist in adults. And it's currently under review at Radiology, which is our kind of main journal out there. And there are a lot of people wanting this. This is a small study, but people are very, very interested.
It also means that with the CT1, you would be able to assess the inflammation in the liver with the CT1 and the fibrosis with the CT1 IQR. One quantitative MRI, which can be done across different MRIs at different hospitals, analyzed by one outside provider vendor, which is Perspectum, right?
That is one interpretation of these data. No, obviously validation. We're the first small study of a little less than 40 patients, but we started early into this game into quantitative MRI, particularly in PSC and autoimmune hepatitis, but even in NASH and NAFLD, these data don't exist yet. And there's billions of dollars of pharma and NIH money going into those diseases, and people still haven't done this, which is pretty cool. I mean, it's bad, but it's good for us. So yeah, ultimately the takeaway here is the MRI probably is going to have a role in detecting and monitoring both inflammatory and fibrotic activity in the liver in these diseases. Although as part of children's, as part of A-Link, we need to figure that out and figure out how to generalize it. So the second project I want to touch on here is MRI correlation with outcomes. And sort of the good news is, it's best I understand it, what I'll call a hard outcome. So liver transplantation, life-threatening GI bleed, encephalopathy. These days in our kiddos, I think it's pretty uncommon. So it gets hard to correlate these MRI stiffness measurements and how they change over time, or CT1 and how it changes over time with transplant, because most kids aren't getting transplants, which is good. So one thing we can potentially use is these prediction models as sort of surrogates for outcomes. So there's something called the Mayo Risk Score. There's something that's pretty new, dedicated to children specifically, called the SCOPE Index, that predicts sort of or forecasts the risk of developing complications and future outcomes sort of in the near term. So the Mayo Risk Score has been shown in adults to correlate with survival, and you can see everything goes into a formula here based on a lot of blood work and age, and you get a low risk score, an intermediate risk score, or a high risk score. For the SCOPE Index, which is PED specific, PSC specific too, it has been shown to correlate with liver fibrosis and, again, outcomes, including transplant and hepatobiliary complications. This uses 4 different laboratory values: bilirubin, albumin, GGT, and platelets, but also uses MRCP or ERCP, typically MRCP, the cholangiogram and how bad the bile ducts look on imaging. And then you come up with a score, 0 to 3, 4 to 5, or 6 to 11 in those ranges for low, medium, and high risk. So the next project, and this is the one that was actually published over the summer, was we looked at the relationships between those Mayo risk score and scope index, which have been shown to predict outcomes in the near future. And how do MRI changes, whether it's MRI elastography, CT1, or now I'm throwing in one more biomarker, which is where we take your child's clinical MRCP and it undergoes a bunch of post-processing and AI. And basically we can get this color-coded map of the bile ducts that we can now use to get at a whole bunch of new novel biomarkers, which I'll show you in a couple of slides. So again, we used the CALD registry, took our baseline examinations at the time, there were 58 of them, and documented the stiffness, the CT1, the CT1 IQR, and now these quantitative MRCP metrics, which are also from a product by Perspective called MRCP Plus. And then we correlated those metrics with the Mayo risk score and the scope index, which were able to be calculated for all of those patients. Briefly, quantitative MRCP, normally, you see the bile ducts on MRI, it's a black and white image, lots of stuff in front and back and, lots of artifacts. This process basically uses AI and different processes to pull out the bile ducts, and then now they're color coded by the diameter. And we can come up with the diameter, what's the diameter of the common bile duct, the right hepatic duct, the left hepatic duct. And then we can define strictures as, say, 50% narrowing of a duct. And how many strictures are there? How many dilations? Say that's 150% increase in diameter. What are the length of strictures? What are the length of dilations? What's the total volume of all that bile there, that biliary tree? And then what's the total length of all the bile ducts combined? So we've got a whole bunch of new numbers here we can potentially look at and see how they correlate with these outcomes. So on the right, you can see the Mayo risk scores for the population or sample. And on the bottom right, you can see the range of scope scores. And it's a pretty good distribution. I will say on the Mayo risk score, there are not many patients in the medium or high risk. Almost everybody's in that low risk. Scope is a little different. Scope, we have patients across all the different risk ranges. The other thing that's important to point out here, these risk scores were developed for PSC. A lot of our patients are PSC, ASC, and or autoimmune hepatitis. So we've put everybody sort of, into these calculators, whether they were PSC or not. So this is for, for everybody combined. The Mayo risk score correlated with liver stiffness, correlation coefficient of almost 0.6. Correlated with CT1 IQR, you can see correlation coefficient of almost 0.6, again, very low p-value. And then also the Mayo risk score correlated with the maximum diameter of the left hepatic duct and the maximum diameter of the right hepatic duct. The correlations weren't as strong as they were with stiffness or with CT1 IQR, but this is interesting. The ductal diameters seem to track with the Mayo risk score. The scope index is even more interesting to me. Now, liver stiffness versus the scope index, the correlation coefficient is basically 0.7. And you can see the scatter plot on the top right. And that's pretty much a line. It's very interesting. CT1 IQR, correlation coefficient is 0.51. Very highly significant. That's the plot on the bottom right. And other than a couple outliers, it actually looks pretty linear as well. And then there are a couple of left hepatic duct diameters that correlate with scope, the left maximum diameter and the left median diameter. So what if we do that multiple regression thing we talked about a while ago, when we put all of those bile duct metrics, say 20 of them, plus stiffness, plus CT1 IQR, and all these age and sex and diagnosis, AIH versus PSC, put it all into a regression model and try to say, hey, what is driving your Mayo risk score? It turned out that stiffness, so every 1 kilopascal increase in stiffness was associated with a 0.3 increase in Mayo risk score. Every 10 millisecond increase in the CT1 IQR was associated with an increase in the Mayo risk score. Here you can see it's 0.04 was the increase. And then every 1 millimeter increase in left hepatic duct diameter, as that duct got bigger, every millimeter got bigger, the Mayo risk score went up on average 0.13. So stiffness and CT1 IQR seem to be driving the Mayo risk score and the left duct. Scope looks very similar. You can see that for every 1 unit increase or 1 kilopascal increase in stiffness, the scope index went up 1.1 units. For every 10 millisecond increase in CT1 IQR, the scope went up about 0.1 units. And then here's interesting for scope. Scope seems to be more driven by the CBD, the common bile duct, the extrahepatic biliary tree. And it's both maximum diameter, which gets bigger when there are strictures, and the median diameter. And as the maximum diameter went up, probably upstream dilation from a stricture, the scope index went up. And as the median went down, as the median went up, which the median diameter goes up, the scope went down, which actually it probably gets at stricturing too, because when you have stricturing, the median is going to likely go down, which is going to drive your scope up. So all of these kind of biologically do make sense. So now we have, again, two metrics that correlate not only with pathology, CT1 IQR and stiffness, but they also correlate with Mayo risk, PSC risk, and with the scope index, and seem to be working pretty well. Even when we split it out by PSC versus autoimmune hepatitis, the results still hold. It seems to be working in both forms of autoimmune liver disease, which is, I think, very interesting. So what's coming up next, other than question time? Two coming attractions. So, I think folks in the room, many of us are familiar with probably both of these. The first is the children's PSC observational study that's ongoing now. I have a couple of slides on that, and then a slide on A-Link. So the Children's Liver Disease Research Network has an ongoing observational PSC study. So this is not an interventional study. We're going to watch kids and watch how they do over time. And we have 11 sites. The last site went online yesterday, I believe, Seattle. And they're doing standardized research MRIs. And these are being done at baseline, a year down the road, and then a few more years down the road. So we'll get 3 time points. And as part of that, MRCPs are being done that 2 radiologists are reviewing and looking at a whole bunch of different findings and documenting whether they're present or absent and taking measurements. We're also looking at the anatomic liver, is there fibrosis, capsule retraction, areas getting bigger, areas getting smaller, increased T2 signal, all those sorts of things. T1 mapping is being done and sent to Perspectum. The MRCP images that the radiologists are reviewing are also going off to Perspectum for the MRCP plus and all of those quantitative bile duct markers we talked about. And then the images are also coming here, and our imaging core is measuring off the images and coming up. And normally when we measure the spleen, for example, in the clinic, we just take a linear measurement. The spleen's 13 centimeters or it's 15 centimeters. Here, in addition to that, we're actually segmenting out the entire liver and spleen and getting liver volume and splenic volume, which we think is going to be a much better biomarker in these patients. And then locally, we're also processing the MR elastography. So in case you're interested, this is a 45-minute protocol. Basically, everything we're acquiring, you can sort of see on the right, but it's a combination of anatomic imaging, MRCP imaging, MR elastography, T1 mapping, and then segmenting the liver and spleen, like you can see on the bottom, and coming up with those volumes. And as of just a couple of days ago, when I put this together, I think 34 examinations have been uploaded to the site, and the images come here, and we've looked at them and done our reviews. So this project is going on. And then just wanted to drop a slide in on A-Link. I think A-Link provides numerous opportunities. I think it's fantastic for our patients, for our providers, for our families. And I would love this sort of network to be able to look at some of these findings, for example, that we've discovered in those 10+ papers, and be able to validate them, perhaps imaging in a multi-center nature. Perhaps A-Link or some other group can help us determine what the appropriate ideal imaging strategies are for AIH and or PSC. Are they the same? Are they different? When should we image? Should everybody be imaged at diagnosis? Should everybody get a 1-year follow-up? Should everybody get a sooner follow-up? If we do image more frequently, how extensive should that protocol, does it need to be everything I showed you, or can we rein it in? What does that look like? Do we need contrast or not? Lots of great questions. And then we need to really elucidate the role for MRI. We've shown all these correlations and associations, but ultimately, how are we going to use MRI as a staging tool? How are we going to use it for predicting future complications? How are we going to use it for guiding treatment? For example, patient with autoimmune hepatitis, if we treat them for 3 months or 6 months and their MRI CT1 doesn't change, does that mean, in IBD or lymphoma or other worlds, if the imaging doesn't change, we then escalate and go on to a second therapy or go up on the dose or something along those lines? So how can imaging guide treatment? And then the last thing I'll mention that's not on here is how imaging can help with clinical trials, both as an endpoint, either primary or co-primary endpoint, minimum of a secondary endpoint, and also how can MRI help determine who goes actually into clinical trials? Because if our patients going into clinical trials sometimes are too heterogeneous, it's very hard, everything kind of gets washed out and you don't see a great result. When indeed, if we had a little more refined, patient population, we might actually see a much stronger result. So with that, I'm done.